Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, up till now we have discussed that what is the structure of chronic hepatitis B virus and what are its clinical implications. Then we discussed the serological patterns of the chronic hepatitis B virus infections. Then we also discussed that what is the life cycle of the chronic hepatitis B. And in the last video, we discussed that what should be the workup before starting antiviral treatment. In today's video, I shall discuss that why patients with chronic hepatitis B needs treatment. What is the rationale behind? Which sort of patients needs treatment and which sort of patient needs monitoring? So let's see what's the rationale of initiating and what's the need of initiating treatment for such patients. So the title of today's discussion is Chronic Hepatitis B, Why to Treat? We all know the natural history of HBV infection is that when a patient develops acute hepatitis B, the patients may recover within 6 months. The so-called recovery, which is I've shown in the green picture, the green color, or the patient may enter the chronic hepatitis B phase. So that is the acute hepatitis B stage. When a patient recovers, the green recovered, or the patient may have an alternate path, that is the chronic hepatitis B path. And from this path, the patient may recover or may not recover. And what happens at times that the patient becomes obviously recovered, but again, the patient may reactivate. So from acute hepatitis B to recovered, it's a one-way process. And if the patient comes to the chronic hepatitis B, then it may recover or it may come back. We know that in the chronic hepatitis B phase, there is fluctuating level of immune reactivity. The immunity of the body does not behave the same or does not react the same way to each and every patient and at each and every time. So classically, the chronic hepatitis B phase has been classified into 4 main phases: immune tolerant phase and immune reactive phase, immune control phase, and immune escape phase. Immune tolerant phase is the one where hepatitis B virus is proliferating, but immunity is tolerating. Immunity is not attacking on those hepatocytes where the proliferation is being done, is there. While in the immune reactive phase, the immunity becomes alert, it awakens, and it attacks those hepatocytes, and practically all hepatocytes, where the hepatitis B virus proliferation is happening. Then, after attacking those hepatocytes, after damaging, destroying those hepatocytes, which has the proliferation of the chronic hepatitis B virus, the inflammation is controlled and the immunity overcomes the proliferation. And now this is called immune control phase. And in the last phase, at times comes that the patient virus escapes from the immune control, and this is called immune escape phase. So 4 phases: immune tolerant phase, immune reactive phase, immune control phase, and immune escape phase. And when we see the profile in these patients, the HBs antigen remain positive in all the 4 phases and becomes negative in the recovered phase. Then the E antigen is positive in the first 2 phases, while it is negative in the last 2 phases of chronic hepatitis B and in the recovered phase. The DNA is sky high in the immune tolerant phase, second highest in the immune reactive phase, then negative or less than 2000 in immune control phase, and again rising in immune escape phase, and in the recovered phase less than 10 units are negative. But when we see the cccDNA, it is present irrespective of the phase. It is present in the acute hepatitis B phase, in all the 4 phases of the chronic hepatitis B, and even in the phase of recovered phase. So we can define hepatitis B, and this is the lifelong existence of the cccDNA in the nucleus of the hepatocytes of a human body. So hepatitis B disease is an invasion of the hepatocytes by CCC DNA and then staying there lifelong. This is the concepts. And it is important that we should be understanding these concepts, because the available therapies for hepatitis B, they just hold on, they just stop the proliferation, they control the proliferation of the hepatitis B virus. They cannot eradicate. They have got no impact on this triple C DNA. So triple C DNA lies there in the nucleus of the hepatocytes, despite the proliferation is being controlled. That's the reason we say that chronic hepatitis B behaves like the hypertension, the diabetes, where you can control the disease, but you cannot eradicate the disease, as we are able to eradicate chronic hepatitis C patients from the liver. We cannot eradicate hepatitis B from the liver. So it means that the CCC DNA lies throughout. In acute, chronic, recovered phase, in acute phase, HBs antigen is positive. In the recovered phase, it is negative. And this is the antigen positive status, negative status, old terminology. The DNA level is very, very sky high in the HB antigen positive infection, second highest in the HB antigen positive hepatitis, then less than that. This is very important. That in the first phase, there is none or minimal liver damage. In the hepatitis phase, there is moderate to severe. And again, there is no additional damage, but the additional damage is done here. But remember that the liver in the immune escape phase is already having some sorts of damage from the second phase, that is the immune reactive phase. And in the recovered phase, there is no additional damage, but HCC chances is there if the patient is cirrhotic and has developed before the HBs antigen loss. So this is an overview of the natural history of the hepatitis B virus patients. We all know that this is the how the ALT is starting in rising and decreasing. The DNA levels is HBs antigen levels. So to summarize, we know from our basics knowledge of pathology that acute inflammation is defined as inflammation and necrosis, and then it is followed by the cleansing phase. While as compared to the acute inflammation, in the chronic inflammation, there is inflammation and necrosis, as it is there in the acute inflammation, but it persists for more than 6 months. And here it is a cleaning phase. It is accompanied by the healing phase. So the inflammation and healing goes side by side. Healing may be in terms of the regeneration or in terms of the fibrosis. In most of the tissues, this is fibrosis going on, like in pulmonary tuberculosis. It is a chronic inflammatory condition, and there is chronic inflammation as well as damage to the lung parenchyma and the fibrosis. Same is for the chronic hepatitis. That in chronic hepatitis, the inflammatory and necrosis process is accompanied by the fibrosis process, and longer the duration of the chronic inflammatory phase, higher will be the amount of fibrosis lying down. So in hepatitis B virus does not damage the hepatocytes. We all know that the inflammation is initiated by immunological attack on hepatocytes. Or so I said before that the chronic hepatitis B, the fibrosis is increasing with the passage of time, and when it reaches the F4 level, the maximum level, the liver starts regenerating because the functional loss is there, and to overcome that, liver regenerates. So the F4 fibrosis plus regenerate nodules is equal to cirrhosis. So to stop the onset of prevent the cirrhosis or improving the fibrosis, what we do when we treat this patient, even the patient fibrosis can be reverted. How it is reverted? Please make your concepts clear. It doesn't mean that the fibrotic tissue will re-change into a normal tissue. No, it is not that way. We know that at any time there is fibrous deposition processes and there is fibrosis cleansing processes, the natural way to clean the process. If the fibrous deposition is greater than the fibrosis cleansing processes, what will be the end result? That with the passage of time, more and more fibrosis will be deposited. But if the degree of fibrosis deposition is less than degree of fibrosis cleansing, then with the passage of time, the residual fibrosis will decrease, and the patient's fibrosis level will decrease from F4 to F3 and F2 and F1. And we have seen this in our clinical practice. When we do the fibroscan, now I am doing this fibroscan for the last 10 years, and I have seen the patient's fibrosis reversing back from the F4 to F3 and F2 levels. I have seen that with the successful therapy of the chronic hepatitis B patients, even with the chronic hepatitis C patient. When we treat them where their PCR becomes negative, where their inflammation is controlled, then with the passage of time, the fibrosis also reverses, and this is the reality. So this is the way that we say that fibrosis is reversible. It does not mean that the fibrotic tissue will become a normal tissue again. No, the fibrosis amount will go down, and we all know the liver has got its regenerative power. So the new hepatocytes and all those things will be made and the fibrosis amount will decrease down. So in immune reactive phase, immune escape phase, treatment is warranted because these are associated with the damage. So longer the duration of immune reactive phase or immune escape phase, there will be high the risk of liver cirrhosis and HCC. And remember that in immune escape phase, the liver is already damaged from this immune reactive phase. So these are the two phases where treatment is warranted. And we all know that higher the level of the baseline viral DNA, higher is the risk of HCC as well as the cirrhosis. This is the data from the REVEAL trial, and it's shown that the baseline HBV DNA is directly proportional to the risk of the patient developing cirrhosis as well as patient developing HCC. So the point is that we should be decreasing the viral load to the maximum level we can do. So if a patient is immune reactive phase or immune escape phase, so the antiviral treatment is warranted. So to summarize, liver damage is the only indication. Liver damage is the only indication to start antiviral treatment. Liver damage is caused when immunity attacks on those hepatocytes which harbor cccDNA. And practically, these are all hepatocytes where HBV replication and viral synthesis is happening. So the first aim will be to avoid liver damage. Inflammation is there, and we want to stop the liver damage being happen. And second is to minimize liver damage by either reversing or halting or slowing down the process of damage. So the first aim is, the first indication is to avoid liver damage. And the second indication for the antiviral treatment is to minimize liver damage either by reversing what has happened or by halting no further damage or by slowing down the process of the damage, that the further damage is done at the slow rate. So these are the multiple ways how we can help the liver to remain healthy or to remain stable. So to avoid liver damage if it is going to happen, and to minimize liver damage if it has already happened. What do I mean by this? If a patient has got hepatitis, like HB antigen positive hepatitis, like HB antigen negative hepatitis, in this stage, the liver damage is going to happen. So we want to stop, we want to avoid the liver damage, and the antiviral treatment is required here. And if the patient is already fibrotic or cirrhotic, even in cirrhotic liver, in the negative PCR, we do recommend treatment. The reason is to prevent reactivation, to minimize the liver damage by if the liver can be the damage can be reversed, or to halt no further fibrosis, or to slow down the process of damage. If that patient fibrosis is changing from F3 to F4, in 6 months' time, it should happen in 1 year time, in 2 year time. So to summarize the whole thing, that liver damage is the only indication for antiviral treatment. And if the patient has got hepatitis, the liver damage is going to happen. So aim of in this category will be to avoid liver damage. But if a patient liver is fibrotic or cirrhotic, so the damage is already done. And here the indication will be to minimize liver damage by reversing or halting or slowing down the process of the damage. But if I summarize, if my patient is in the HB antigen positive infection phase or HB antigen negative infection phase, and inflammatory process is on. So we need to start these patients on antiviral treatment. And remember that with the current therapies, we can only control the treatment. We can only control the proliferation. So the treatment is required lifelong, practically lifelong. We hope in the years to come, we will be having a treatment where the virus will be able to eradicate the virus from the hepatocytes, will be able to eradicate the cccDNA. And if we can do that, it will be a defined or finite therapy, maybe for years or 2 years or something like that. But till then, with the current therapies, if the treatment is started, it's a lifelong treatment. And please don't stop the treatment, because if you want to stop the treatment, you will stop only if the patient's liver is perfectly all right. Patient was initially HB antigen positive hepatitis. In that condition, you can think about stopping treatment, but there are so conditions for that and close monitoring, then even in that case, it is not cost effective. So better to continue with the treatment of your patients, because this is the only way you can help the patient to remain healthy or relatively healthy, and to avoid cirrhosis. And if the cirrhosis is there, to avoid its further deterioration. I hope in this video, I've been able to give you the rationale why the antiviral treatment is needed, and why not all patients needs treatment. Because if the damage is being done, a damage is there, a damage is going to happen, then you will start treatment. Otherwise, you will follow these patients with very close monitoring. Thank you very much. Inshallah, to see you in another video. If there are any questions, please do ask. I would love to answer that queries of yours in the chat section. Thank you very much.